Professor of neuroaudiology and a very good friend of mine, who is also an excellent researcher, Professor Doris Eva Bamiou. She's working in London and will take us on a journey, as promised, beyond the gold standard evaluation of hearing, the audiogram.
Okay. Thank you very much for the very kind introduction, Vivian, and thank you so much for including me in this very interesting day. Let me see if I can share my slides. Yep. So hopefully you can see this.
Yes, thank you.
So what I'd like to talk to you about today, following these very interesting talks, is the need to evaluate hearing beyond the audiogram, which is the first test anyone thinks about when we mention the word hearing. And that's because whether you're a human or whether you're a rodent in the fields, your hearing is very important for your well-being, but also for your survival. And hearing is not just about getting aware of sounds. It's also about computing these sounds to derive meaning, and that meaning will inform your decisions and actions. For example, when you're a rodent, you need to compute the sound waves of the rustling wings of an owl who's flying to you in different parts of the auditory pathway to recognize where the owl is flying from, how fast it's flying towards you, when it will reach you, and then you have to make a plan to escape. For humans, well, we live in a very complex world, and acoustically it's also very complex, and it's also dynamically changing all the time. It's got a lot of sounds and they change over time. And our auditory system is really a marvel because it breaks down these sounds into physical properties, how loud they are, what is their frequency content, but also timing information, which is so important about the sound. And this is a process that we need to do because then the sounds at higher levels of the auditory pathway are grouped into different streams. And we become aware of, like others said before me, well, the sound of a current near us, or a river, or the sound of music, or a human voice. And our system matches these auditory objects into stored templates and corrects this matching by a process called active inference. And listening is a cognitive and an active process, and we use knowledge, we use attention, we use memory, and all this process is important for us to be able to participate in a conversation with a group of friends, to enjoy and appreciate music, to recognize that a car is coming towards us, so we've got to stay where we are or take a step back, etc. So over the last 6 decades or so, the notion of auditory processing disorders has gained firmly more ground in science. And we use the term central auditory processing disorder or auditory processing disorder to refer to difficulties in the perceptual processing of auditory information within the central nervous system and the neurobiological activity that underpins this processing. And we use this term as an umbrella term for a variety of disorders that affect the way that the brain processes auditory information. Now, pleasingly, the most recent World Health Report on hearing has included a section on auditory processing disorders, and Professor Ηλιάδου has truly been instrumental in bringing this forward, and we're all very grateful to her. Because you would argue, okay, why do you need to think about this as a diagnostic entity? What's the use of one more label to describe what patients and others experience? Well, we need labels to communicate between us as professionals, but also to communicate with the public. We need a label because it will inform how we provide clinical care, which, however, is not only based on the label. It's deficit-based, and we try to provide precision intervention. We need a label for research purposes when we try to look at the gene's effects on how we hear and we listen. We need it for epidemiological purposes. So we use the term because then we need to establish, is this a frequent problem? How frequent? And what resources would be needed to address this? And obviously, you need the label at a health policy level to inform the need for services and to construct a care framework. However, beyond that, the professional domain, as a person, if you experience this problem, well, there are benefits to having a name to call it with. Because unfortunately, it shouldn't be like that, but atypical behavior is more acceptable when there is a known clinical diagnosis. And this is a problem for both children and adults who can be perceived as unruly or uncooperative because they don't listen well. If you have a label, you're also less likely to be for this to be associated with low self-esteem. Again, I see that a lot on the pediatric side where I work, where clients who come to me for this assessment, because they get the feedback that, you know, they don't listen well, and they start worrying whether they're dumb or whether they're doing something wrong. And this affects how they perceive themselves. It's also been reported that if you identify with a group, well, this has positive effects on your well-being. And unfortunately, we need to be honest, when you have a diagnosis, you're more likely to attract attention and support. So we recently ran a study on an auditory processing disorders support group of patients in Facebook. It was an anonymized patient survey, and we published that last year. We wanted to know about the experiences of patients or people with auditory processing disorders within the health section, education, and at work. And unfortunately, as you will see from this graph, the majority of the respondents had experienced, had some quite negative experience. So the first major domain of difficulties was they found it difficult to get referred for assessment for this diagnosis, either because their primary care physicians were not aware of APD, or because they were reluctant to give a referral because they thought, well, what's the point of getting this diagnosis? Then, after they got the diagnosis, well, 3/4 of these had difficulties getting support that they needed, whether that was funding for an assistive listening device or other kinds of support, because at schools, at work, they were told again and again, and this actually was a mistaken feedback by the school or by work, that APD was not recognized as disability, because APD is recognized as a disability within the education sector in the UK and elsewhere. Another domain of difficulties was, well, negative experiences with local authorities and even within the NHS. Because, again, awareness between professionals, even between professionals who need to be aware of this condition, is still quite low. And finally, there were problems because, of course, very few people within the public would recognize what APD means. Teachers don't get any training at present to learn how to support these children, and they may be overworked, they may not want to know necessarily, and employers may not believe in APD or may wish not to believe in APD. So we wanted to keep things on a positive note, and then we asked how this could be improved. So there were several suggestions and ideas for research, and are there areas for support. But if you look at this graph, again, the majority of the respondents highlighted the need for medical and other professionals to be given special training. And they also wanted APD awareness to be raised within the public. They wanted, of course, schools and teachers to be trained. And they wanted more governmental policies to support individuals who get this diagnosis. And in terms of research, they had several recommendations. They flagged the need for screening services, for intervention programs, etc. So it's interesting that when we ran this survey, APD was already within classification manuals. This is from the International Classification of Disorders version 10 of the World Health Organization, which gives a diagnostic code for APD or CAPD, which we use. And in the forthcoming ICD-11B, again, there is inclusion of this category with a little bit, more information about it. And hopefully, when the new version will be released, this entry will be there the way I'm showing this screen to you. But beyond having a label, there are, of course, other issues to consider. So the major problem at the moment is, what about a diagnosis? What are the diagnostic criteria? And there has been a lot of discussion recently about these. And I think, again, in the last 5 to 10 years, there has been very significant progress, because now we do have criteria. And in this study, from Europe, where you see our names with Professor Ηλιάδου and several other medics who come across patients with these difficulties, we managed to come up with a consensus for the criteria to use for this diagnosis. And if I take you through these, a starting point is that these individuals will have normal hearing thresholds. That's not always the case, but particularly for children, it will be very difficult to bypass this criterion. And then the crux of the matter is, you can't say that someone has got APD until you've actually conducted specific, detailed assessment of their listening difficulties. And the criteria for this diagnosis, you need to identify 2 abnormalities. And beyond the abnormalities, you also need to have listening behaviors that raise the suspicion of APD. For example, problems listening in noise, problems with fast speech, taking a while to come up with a response, and so on. We also specified in these diagnostic criteria that you need near normal intelligence. Again, particularly in the research domain, this criterion can be bypassed, but it would be very difficult with the current test that we have to make this diagnosis unless the non-verbal IQ is near normal. And of course, we also specified that you can give this diagnosis if you think that the person whom you are assessing can follow the instructions for the test in ideal conditions. So, for example, somebody who's very anxious or depressed, and anxiety and depression is not appropriately managed, or someone who is not reliably responding to the test because, for example, they have an attention deficit disorder which is unmedicated, or even someone who is not giving you very consistent responses because of other reasons, well, you can't take the abnormal results at face value. So you need to be very careful who you provide the diagnosis to, and these diagnostic criteria are a starting point. Remember, however, if you want to assist these clients, you start with an audiogram, you start with basic tests of hearing, but this is hardly enough. You need a multidisciplinary assessment and approach. Before you start your assessment, firstly, you need to be clear about your definition for APD and your diagnostic criteria. And I'm very clear that my definition and criteria follow the European consensus. You need to consider use of different tests for individual clients. You need to consider the different population characteristics, okay? For example, you may live in a multinational society with several bilingual clients, and that will affect how you use your speech tests or how you interpret these. You need to think about history and risk factors. For example, clients who come to me after a traumatic brain injury are more likely to do auditory brainstem evoked responses on them than on the rest of the patients. You need to carefully consider if you have normative data for the population you're assessing, and also, of course, the time that you have available for the assessment. For example, in my National Health Service clinic, I've got an hour and a half to 2 hours per client. Sometimes I would love to do additional assessments, but I am constrained by the clinic time. And of course, you need to consider the purpose of the assessment. Is it just to provide a diagnosis? Is it to monitor improvement, for example, after an intervention? Is it to define beyond the diagnosis the degree of the functional deficit, so you can tell others how serious this is? Is it for medico-legal purposes, and so on? Nevertheless, additional assessments are fundamental to the diagnostic process. So, as I said, you need to think about the cognitive levels of the patient, or if you suspect a speech and language problem, again, you need to have an assessment of the speech and language domain because this will affect your interpretation of the results. And there is a lot of clinical decision-making when you see the client, you take the history about the test that you're going to choose. So as I've already explained to you, the approach is driven by the exact clinical question you try to answer, and you're also influenced by the patient background. Occupation. Mark talked to you a lot about noise exposure and how it affects hearing. And I would do more elaborate peripheral hearing tests on clients who have a significant noise exposure history. Education levels are also important, and performance within education, that gives me a little bit of a guideline. I assume that a child who's a top student also has pretty good cognitive levels. When I look at the test results, I'm more likely to take into account borderline findings. Language aptitude, you know, if a child comes to me with a language disorder diagnosis, well, I'll do more limited or simpler language-based auditory processing tests. And also musical expertise. Musically trained individuals are likely to give you better results in several or most of the auditory processing tests. When I take the history, I want to ask about symptoms, and then I consider deficits within specific domains. Speech and music domain, they are overlapping, okay, but not completely. Okay, I've got several music clients who come to me and they have speech and noise deficits and related complaints. I ask about environmental sound awareness and perception, even in children. You'll be surprised how many children who come to me are not aware of sounds around them. Spatial analysis, is localization of sound okay? And emotional analysis, particularly in adults, can they appreciate the emotional content of a musical piece, for example? But also, can they understand prosody and emotion in people's voices? I also consider sound aversion, hyperacusis, that is heightened sensitivity to loud sounds, misophonia, a favorite disorder of mine, and musicophilia, which is another very interesting presentation that we see in older adults with different dementia presentations. I ask very carefully about risk factors for their hearing and auditory processing, and so I take a history, a medical history, which is quite extensive. I also ask about family history, developmental disorders, hearing loss, other individuals affected with similar symptoms in the family history. And again, I put everything within the social, professional, educational context, in the sense, why does this client come to me requesting this assessment? What do they want to use this information for at work, in education, for their social life? What is the problem they experience? Okay, and I can be upfront and ask, what is the problem that you have? What is your first concern, and how would you like me to help? And then, unfortunately, we always need to consider what are the resources available, because you may think, okay, I can do X, Y, and Z, but if the patient, you see, doesn't have the money to buy these wonderful listening devices, or the school is not very likely to support them, you need to factor this in and think of other remedial strategies or how you're going to influence this. And all this is always driven by the patient needs and their wishes. Okay. So what are the risk factors for APD? Well, I've written a paper, for God's sake, 21 years ago. I'm that old. And I've updated the graph from that paper. There are neurological conditions, okay, head injuries, stroke and other events in adult patients predominantly. Meningitis, epilepsy, occupational noise and metal exposure, multiple sclerosis, genetic factors, and other conditions such as psychiatric disorders that Professor Ηλιάδου has mentioned and is working on. Another key category is auditory deprivation, the child who's experienced glue ear, other kinds of hearing loss, because this affects central nervous system maturation, or it affects central nervous system organization, even if you acquire hearing loss as an adult. To some extent, even those with a peripheral ear-related hearing loss will also have auditory processing problems just because of the way that the auditory system operates. You see that there is a lot of overlap of APD with other developmental disorders and conditions: attention deficit disorder, dyslexia, developmental language disorder, autism, etc. Age-related changes and cognitive disorders associated with age-related changes like cognitive syndromes. And of course, tinnitus, hyperacusis, but also hallucinations, whether they're hearing loss related or musical hallucinations, or whether they're within the context of a psychiatric presentation, may be perceived as a disorder of auditory processing due to hyperactivity within the auditory system. So, beyond your assessment of the patient in terms of getting a history, you do a baseline audiological assessment. Of course, you start with a pure tone audiogram. You can't bypass this test. It's very informative, it's very well validated, but it does not suffice. You also may need to do word recognition in quiet, otoacoustic emissions with suppression, tympanograms and acoustic reflexes and/or auditory brainstem evoked responses. And in all honesty, you don't do all these tests in all the patients, but you actually choose which of these tests beyond the audiogram you cannot afford not to do in a specific client when you have to operate under time constraints, as I do. But after you had the baseline assessment, you need to think and include other tests. Why? Well, this was a study that we published a few years back, and this was a study of adults, working age adults, who came to my clinic complaining of different listening and hearing difficulties, and yet they had completely normal audiograms. Okay. And we ran a test battery of auditory processing tests, and on the basis of these, we classified them as a clinical group who had auditory processing disorder, a clinical group who complained of difficulties, but they did not meet criteria for APD, and we also recruited normal controls. And we ran a couple of questionnaires, the Amsterdam Inventory and the Speech Spatial Quality of Sound questionnaire. And I won't take you through the results, but just to say that the group who was diagnosed with clinical APD gave much worse scores in all domains in the questionnaires compared to the controls, and also to some extent compared with a non-APD clinical group. And when we ran a correlation analysis, the questionnaire results strongly correlated with the auditory processing tests, but not with the pure tone audiogram. So this tells you, if someone comes to your clinic and they complain of hearing and listening problems, and they're normal, you don't suspect a stroke, they're working age, they don't have a hearing loss, and you do the audiogram and you confirm that the audiogram is normal, well, don't stop there, because their problems that they report will correlate with deficits in auditory processing tests. And it's important to identify these deficits, because you can then help the patient appropriately. Beyond the non-neurological groups, of course, you see that, for example, in patients who have stroke. And in this study that we did with my then PhD student, Nezat Kui, we looked at a group of stroke patients versus controls, and the hearing thresholds, because we recruited controls to be age matched and hearing matched, were not different in the controls to the stroke group, but the stroke group had a much more frequent chance of having disordered auditory processing and central auditory processing disorder, or when they were younger, just have auditory processing deficits without any impairment of peripheral hearing. And in a follow-up study to this one, we proposed that you need to screen these individuals, not just by briefly assessing their hearing, for example, with a screening audiometer, but also by running a questionnaire to identify those who need further assessment for auditory processing. Now, this is another interesting and unpublished as yet study, and Jeremy Johnson is my PhD student with Jason Warren, and this is a very complex heat map. So let me tell you that what this shows you on the vertical axis are the auditory domains from the Amsterdam questionnaire with the individual questions. On the horizontal domain, you see first column is the audiogram, then it's the speech in bubble, which is a words in noise test, and then you have other auditory processing tests. And the darker colors mean low correlation, and the lighter colors say strong correlation. And you can see that you have much more lighter colors from the speech in bubble and in the other rows of auditory processing tests versus the first column, which is the audiogram. In other words, in a group of patients with different kinds of dementia who also have impaired hearing, it's not the audiogram that corresponds that much with their listening problems as the auditory processing tests. And that's very important to keep in mind. And I think the first speaker spoke about the Lancet study, which showed a very strong correlation and increased risk for having dementia if you have hearing loss. Well, this recent study actually found that having speech in noise hearing impairment actually gives you a heightened risk of incident dementia. And this is valid for all follow-up intervals of these individuals. So remember, there is a lot of noise at this point in time that hearing loss is actually driving risk for dementia. Let's not forget speech and noise impairment. Okay. So what do we do in the clinic? Well, in the clinic, we do an elaborate auditory processing assessment. I won't take you through these tests because I think I'm running out of time, but there are also validated tests in several languages, including Greek. If anyone is interested in this, contact Professor Ηλιάδου. She's got an excellent test battery. Who should be in the team? Well, you need doctors. You need those who will assess the hearing. In my country, this is audiologists. You need people who will manage these individuals. It can be teachers of the deaf, hearing therapists, occupational therapists, but it can also be other individuals like speech and language therapists. And of course, you need other people to assess them, psychologists, speech and language therapists, and so on. And how do you manage? Well, the goal of management is to improve the functional deficit because this is impacting on their lives. And the management approach can be function-driven, but it can also be test-driven. And what you can do, you can modify the listening environment, you can make it acoustically friendlier, For example, by putting acoustic paneling that absorbs noise. You can implement speaker-based adaptations, and you can understand yourself when I speak more slowly and I try to enunciate more clearly. This makes it easier for you to follow what I'm saying. And you think about remote microphone hearing aids, and there is some interest now in low-gain hearing aids that may assist these clients. You can implement different listening training games and programs. And you can also suggest different kinds of language-based, cognitive, metacognitive, and educational strategies. But also you need to think about additional support. If the client has also a lot of anxiety, if the test results tell you that something is wrong neurologically speaking, if you think about a developmental condition that is not diagnosed, well, you need to think and implement additional assessments or additional management strands. Is there evidence? Yes, there is, both for children, and that's the top study we published a couple of years ago, and also the bottom study we published quite a few years ago about auditory training. And this is both for children, and this is another of our studies about remote microphone hearing aids for stroke patients. So this is my final slide, and I think I've kept well to time. Your learning points. When you come across someone who complains of listening problems, you start with the audiogram, but this is hardly enough. You need to think about a test battery that you're going to implement, and you need to adopt a multidisciplinary approach, both to diagnose and then to manage. It's very important to identify and then explain the deficits in each client. The clients want to know. It's actually a huge relief to some of them that they're not getting mad when they're older, or they're not stupid when they're younger. There are problems that explain why they can't listen in certain situations. But you also need to explain to yourself what is the mechanism of the deficit that you observe, because that will inform your further management approach. And you need to remember, if you want to manage these individuals, you need to do thorough multidisciplinary testing, but you cannot not do that, because this is very important for your clients' overall quality of life. So thank you very much. And
thank you, Doris. Thank you very much. That was really interesting. And I think there is a lot of information there for our audience. And now let's see some questions that we have for all speakers. But first, let me assure Mark that the link in Safe Listening link is up in the chat, so anyone can access that, as well as the other links for the WHO report on both safe listening and the Wikipedia on safe listening and the WHO report. So everyone can access that not only at present time, but also later on. This session will be recorded, and anyone connecting to the live media website at the open access that we have for the Congress can actually watch it